So hey everyone, so in this video we are going to discuss about the case of hernia, and also we will discuss about the theory related to the hernia. Basically we are going for indirect hernia in this case, and then we are going to discuss about some Viva questions that has been asked in my second year, third year and this fourth year as well. I'm not including every question, but the different types of question that has been asked in my Vivas, and also to other people's as well, like my friends as well. So let's start with the points that to be covered. So basically we are covering first of all the case, then we will be discussing about the theory related to case, then the frequently asked questions we will be doing. So basically here it starts. So the summary, we are directly jumping on to the summary. So basically my patient name is XYZ, and he is a 70-year-old farmer by occupation and a patient of asthma since 1 year, and he is a chronic smoker for since 40 years with chief complaints of swelling over right groin region since 1 year, and which is insidious in onset and gradually progressive. The swelling was insidious in onset, and the swelling was measuring 8 into 6 centimeter currently, and which is painless and reducible in nature, and there are no signs suggestive of any strangulation or obstruction. Next, moving forward to the theory. So basically hernia. So hernia is basically the abnormal protrusion of a viscus or a part of a viscus through the wall containing it, which is a basic definition of hernia, which can be asked to anyone. Next, the sites or the common types of hernia we will discuss. So basically common hernias are inguinal hernia, incisional hernia, which can happen after any surgery. Then we have femoral hernia, epigastric hernia, and umbilical hernia. Also there are some rare hernias which are obturator hernias. Spigelian hernia is also there, which comes at around this position of semilunar line, which is like lateral to the rectus muscle, and it is actually basically asked sometimes as a Viva question that what do you know about the Spigelian hernia. Next is the lumbar hernia, and the last one is the gluteal hernia, and these are the sites, and this image is taken from the SRB. All the stuff in this is taken from the SRB, and some stuff minor stuff is taken from the Bailey and Love. Next, the common types of hernia. So most common type of hernia in male is inguinal hernia, and out of that as well, indirect is more common in at age group of 40 to 60 years, and also direct is there, but still indirect is more common. Now we'll discuss about the etiology. So first etiology is straining. When we strain, there is an increase in the abdominal pressure, which actually pushes the abdominal content through the weak sides of our muscle or the abdominal wall. Next is lifting heavy weights. It is also etiology. The chronic cough, which is seen in bronchitis patient. Then we have chronic constipation in old patients. Then if we talk about the urinary cause, we have BPH and stricture and phimosis. These are the condition in which hernia can be seen. So in BPH patient, it is more common in old male patients, and it is one of the Viva question we will discuss later. Then next in pregnancy as well, then ascites and smoking. So the most commonly asked question here is why smoking and how it causes hernia. So first of all, reason is because of the chronic cough. The hernia is possible, and the most usual or the technical reason or most technical reason for that is premature collagen breakdown due to the abnormal amount of matrix metalloproteinase and their inhibitors. So basically there is a certain homeostasis is there between the matrix metalloproteinase and their inhibitors, but due to these smoking, the inhibitors increases of this protein, and there is decrease in the matrix metalloproteinase, which increases the collagen wrong formation, and which break down and which can lead to decreased abdominal strength of the muscles. Now the parts of hernia. So basically there are three parts of hernia. There is a covering, there is a sac, there is a content. The covering has layers of abdominal wall, and sac has a neck and content. Sac has neck, body, and fundus is there. So basically the neck is this part of the sac is neck, then this is body, and the last part over here it is fundus. Then content, it can be omentum, intestine, bowel, urinary bladder, mucus diverticulum, and appendix, and according to the content their names are different. Like in omentum, it is known as omentocele, when the content is intestine, we call it enterocele. In bowel, we call cystocele. Then in Meckel's diverticulum, and then we have appendix and amends hernia. I'm not able to remember for the Meckel's diverticulum. We will discuss later. Then the classification. Now the contents of the inguinal canal. So the contents of the inguinal canal is, so it is spermatic cord in males. Then we have ilioinguinal nerve and round ligament of female. Round ligament in females. Next is content of the spermatic cord. So it can be remembered as vas deferens. Then 3 arteries are there: artery to vas, testicular artery, and cremasteric artery is there. Then there is a genitofemoral nerve, then pampiniform plexus of vein, remains of the processus vaginalis, and sympathetic plexus around the artery of the vas. And the testicular vein is also known as the pampiniform plexus, as everyone knows. Next is the covering of the spermatic cord. So basically the covering of the spermatic cord is derived from the abdominal muscles, fascia and L as well. So I have just drawn this diagram, which is giving that the fascia transversalis, this will continue downwards to become the internal spermatic fascia. The middle layer, the internal oblique muscle or the aponeurosis, will continue as a cremasteric muscle, and the external oblique muscle or the aponeurosis will continue as a external spermatic fascia. Now with the boundaries of the inguinal ligament, so anterior it is external oblique aponeurosis, posterior is fascia transversalis, superior is a conjoined muscle, which is basically. Now the defense mechanism of inguinal canal, which is very much asked question in the Viva. So it is a obliquity of the inguinal canal, the arching of the conjoint tendon, the shutter mechanism of internal oblique, and then we have ball and valve mechanism, in which ball is testis and valve is basically the superficial inguinal ring, and then it is contraction of the cremasteric muscle which plug to the superficial ring, which I have all studied in the first year. The next is when external oblique muscle contracts, the intercrural fibers of the superficial ring opposes, causing slit valve mechanism as well, and the last one is hormones. So these are the defense mechanism of inguinal canal. Now a most common site, which is a Fruchein's myopectineal orifice. So it is basically formed by the pectin pubis inferiorly, then medial it is formed by the lateral border of rectus sheath. Then we have arching fibers of internal oblique and transverse abdominis, and at the lateral side we have iliopsoas muscle, and this actually tells us about all the inguinal hernia or the sites of the hernia at the groin, which is when it is above the inguinal canal we have direct hernia and indirect hernia, and it is when it is below the inguinal ligament it is femoral hernia. Now the inguinal hernia can be of two types, as we know that, direct and indirect. So direct hernia is basically when the hernia comes from the Hazelback triangle. Hernia, which is lateral to the inferior epigastric artery, this is the site for the inferior indirect hernia. This is what the walls of the Hazelback triangles: the medial wall by rectus sheath, lateral border of rectus sheath. Then we have inferior epigastric vessels and inguinal ligament at the base. Now we'll discuss about the types of the indirect hernia. So there are two types of indirect hernia. One is incomplete and the second one is complete. So complete hernia, the hernial sac and all the contents reach up to the bottom of the scrotum, but in incomplete hernia it reach up to the bubonocele or the funicular seal. Basically bubonocele is when sac is confined to the canal only, and funicular when it reach just more to the superficial inguinal ring, crosses superficial inguinal ring, but it not reaches the scrotum, of course, which is in between superficial inguinal ring and scrotum. Then we have a pantaloon hernia, which means there is both direct plus indirect hernia is there. Next is Gilbert versus Naes classification, which is frequently asked. Basically Naes classification is generally asked. So this over here is Gilbert classification, but we will discuss about the Naes classification. So type 1 Naes classification suggests that the indirect hernia with normal deep ring. In type 2 it means the dilated deep ring is there. In type 3 there is posterior wall defect. Next is type 4, which is recurrent hernia. So these are the classification. The Gilbert classification you can read it from here. Now the indirect hernia, which is 65%, is most common and bilateral in 30% of the cases. The precipitating factors are same as of hernia. We have seen the cuffing, the increased abdominal pressure due to various conditions. Now the clinical features. So it is very commonly seen in males. It is 20:1 ratio. There is a dragging pain and swelling in the groin region. These are the two main clinical symptoms of indirect hernia. Now the test we perform for indirect and direct hernia to differentiate as well as to know whether it is hernia or not. So next is ring occlusion test. So in test the contents are reduced and thumb is placed on the deep inguinal ring and the patient is asked to cuff. Cuff impulse is present medially, which means the hernia is direct, and if it is present on releasing thumb, the swelling is present on releasing the thumb, and then we will tell the patient to cuff, and it is on that area, which means it is a indirect hernia which is coming from the inguinal canal. Now the ring invagination test. So basically after we will first reduce it with the little finger is invaginated and patient is asked to cuff. If impulse felt on the tip, like first we will do it like this, it is a finger and we are going into this. Now if the patient cuff and the impulse is felt on the tip, which means that it is coming from the inguinal canal and the patient and the hernia is of direct type, and when the cuffing impulse is coming from the medial side and which is we are feeling it on the pulp, which means that it is a direct hernia. Now the third test which is done, which is the three finger test or the Siemens test. In this we will take three fingers, our three fingers, the index finger, the middle finger, and then we will do the ring finger. So the index finger is kept on the deep inguinal ring, the middle on the superficial inguinal ring, and ring finger on the saphenous opening, and we will tell the patient to cuff. When the patient cuff, we will feel some impulse. If it feels on the deep inguinal ring, which means that there is indirect hernia. In middle finger, indirect hernia, and if it feels on the ring finger, which means it is a femoral hernia. Now the leg raising test. In this case we will tell the patient to sleep in a supine position, and we will tell the patient to rise his leg at 90 degrees as much as possible, up to the 90 degrees, and we will tell the patient to cuff, and we can appreciate the swelling when the patient cuffs. So this is the leg rising test. And the other test like we will do is per rectal examination, which is not done for the hernia, which is actually done to rule out prostate in old male patients. The next is silk glove sign is also performed in these patients. So this is a hand, and these all three important tests are here, it is given. So basically through thumb we will do the deep occlusion test, and these three fingers we will do the Siemens test, and at the end for the little finger we will do for the invagination test we will use our little finger. Now the differential diagnosis. So this is also important question which is asked. So it is the hydrocele, it is in that region which can be infantile, encysted, large vaginal or bilocular. Then we have undescended testis, then we have femoral hernia, lipoma of the cord, groin abscess, hydrocele of the canal of the neck, which is in females. Then we have inguinal lymph node enlargement. Herniorrhaphy, we will do herniotomy, along with we will strengthen the posterior wall of the inguinal canal, which is done by suturing. Then we have hernioplasty. So in this, herniotomy is followed by reinforcement of abdominal wall using a mesh, which is commonly done in Lichtenstein mesh repair by polypropylene mesh. Next we will discuss about the hernia. Herniotomy is basically done in pediatrics patient, because as the age grows the muscles will build and the strength of the abdominal muscle will increase day by day. Now in Herniorrhaphy there are 3-4 procedures is there. The first is Bessini's, which is also known as the father of modern hernia repair. Then we have Desarda technique, which is invented by the Mohan Desarda. Then we have Shouldice repair, and then we have McCabe repair. So some tricks that I have made to learn these things. So first one is Bessini's. So of course after B we have letter C. So in Bessini's we have conjoint tendon suture to inguinal ligament. Then we have Desarda. So after D, E alphabet comes. So external oblique tissue flap reconstruction is there in Desarda repair. In McVay C is there, but here C is copper ligament and not conjoint tendon, which is sutured to the transverse abdominis. And in Shouldice, which is very common in Herniorrhaphy and which is very strengthening technique. In this, after S we have T, so transversalis fascia. So we will do double breasting of the transversalis fascia. Now we will discuss the layers of the Shouldice repair. So first, the lower transversalis fascia flap is sutured to the elevated upper flap, which is done posteriorly, and then we will suture it the lower layer first, then the second layer is the upper layer over here. to the upper TF to the inguinal ligament, we will suture it. Next, conjoint tendon to the inguinal ligament, it is sutured from DIR to SIR, from deep to outside. Then we will go in the fourth layer from superficial inguinal ring to the deep inguinal ring. Now fifth and sixth layer is the external oblique aponeurosis, sutured it is in 2 layers. So basically in shoulders there are 6 layers, the double breasting of external oblique aponeurosis and transversalis fascia is done. Next is the hernioplasty. So most common hernioplasty which is performed is Lichtenstein repair, and it is done via polypropylene or the proline mesh, which is around 18 into 5 centimeter. 18 is in length and 8 centimeter is in width. Then we it should overlap 2 to 2.5 centimeter over the pubic tubercle. This is one of the rule. And the other methods which are there, which is Nyhus, which is a sublay method. Then we have Gilbert. Then we have Stoffas, and then we have Kugel method. But most common which is asked in Viva as well is Lichtenstein hernioplasty. Then we have Stoffas, which is also asked. Now the complications of the open hernia repair. So it is hemorrhage, hematoma, seroma, hematocele, infection, osteitis pubis. Then we have post Herniorrhaphy, hydrocele, lymphocele, hyperesthesia over the medial side of the inguinal canal. Then we have recurrence of 10 to 15%. Then we have injury to the urinary bladder, bowel and the ileus. Now the laparoscopic repair. So it is transabdominal pre-peritoneal mesh repair, which is TAPP. In this technique we will use 15 into 10 centimeter mesh, and it is placed in the pre-peritoneal space via peritoneum. So in this technique we enter the peritoneum in laparoscopy, and then we will enter the peritoneum, and then we will come in the layer and first reduce the mesh, reduce the sac, and then we will place the mesh. But in TEP technique, which is a better or advanced than TAPP, so it is totally extraperitoneal pre-peritoneal approach. So in this 15 into 15 centimeter mesh is placed pre-peritoneally without peritoneal approach. In this technique we will insert the laparoscopic, and we will not enter the peritoneum. We will directly enter the layer which is like this. If we consider this is a peritoneum, we will not enter the peritoneum which is below there. We will enter over here, and then we will place a mesh above over here, and then we will take the laparoscopic trochanter as well out of the site. So this over here it is the the ports which is sent. This for technique we have 10 mm port and 5 mm 5mm2 ports are placed below umbilicus in this straight line, and in TAPP 3 ports are also there. So in TPP with umbilicus we will give a 10 mm incision, when 5 mm incision on the right and the left side is given in these patients. It's more common in these two triangles. The first one is a triangle of pain, and the second one is a triangle of doom. Triangle of pain it is known as because if we injure any part in the triangle of doom, there are basically the contents in triangle of pain are nerves, because after cutting these nerves there will be decreased sensation or in that particular area of the nerve sensation. Next we have, so the contents of the triangle of pain are the lateral femoral cutaneous nerve of thigh, the inferolateral margin of the femoral branch of genitofemoral nerve, and anterior femoral cutaneous nerve of thigh. And contents of triangle of doom are external iliac vessels and external iliac vein and arteries is there. And if it get incision, or we will suture it, or we will place the tacker at these triangles, there will be damage to this vessel, and if any injury is there to the vessels, there will be profuse bleeding. And also these boundaries are also asked to the, like in Viva question, these boundaries are also has been asked. Now this is showing the sublay and method. So in this you can see this is a normal anatomy of the abdominal muscles, and in pre-peritoneal approach for TEP we will go over here, we will not enter the peritoneum. This over here is peritoneum, we will place the mesh above the peritoneum in this place. But in TAPP we will go into the peritoneum, and then we will enter this place and we will place the mesh over here. This is the difference between TAPP and TEP, and this over here it is a clear view of showing triangle of pain and triangle of doom. This is basically from the inside. We have been shown that this over here over here this is a Hazelback's triangle, then we will have this as a triangle of pain and this as a triangle of doom. This over here there will be pubic tubercle, and then this over here the anterior superior iliac spine, and this is the inguinal ligament over here. Now we will discuss some of the questions. So basically hernia questions are: define hernia, we have discussed it earlier, that is a abnormal protrusion of a viscus or a part of viscus through the wall containing it. Now classify hernia, we have already learned in this video. Then why do we USG in hernia patient? To rule out any prostate condition, BPH or ascites, and also the other organomegaly conditions. Then why do we PR in the old male patient? The answer is same, for benign prostatic hyperplasia, because we have to diagnose that and treat first BPH, then only we will proceed for the surgery of the hernia. Then define Herniotomy, Herniorrhaphy and Hernioplasty we have done. Then the walls of inguinal canal, then the ball and wall mechanism we have discussed, then the Hazelback's triangle boundaries we have discussed, then differentiate between hydrocele and hernia. So we have discussed that the main point is we can go above the swelling, then trans illumination test is positive. So these are the some of the differences. Then we have types of repair in hernioplasty. We will learn that Nias is there, Stoppas is there, Lichtenstein is, which is the most common. Then tap versus tap and their full form we have discussed. Then non-reducible obstructed versus triangulated versus incarcerated hernia we have discussed earlier. Now the types of mesh, we have discussed that polypropyl and propylene mesh is there, which is most common is there, and the sizes are different in laparoscopic and in hernioplasty. Then types of hernia we have discussed. Then the investigation to confirm hernia patient is basically the X-ray and the USG abdomen is done. Like hernia versus other groin swelling is there. Now how chewing tobacco and smoking causes hernia we have discussed earlier. Then what will be the next step if your patient is having prostatomegaly? So first we will do the surgery of the prostate. If it is BPH, we will go for the TURP, transurethral resection of the protein, or the open surgery depending upon the scoring and basically age and everything. On that basis we will go for the open surgery or the TURP surgery. So this is from my side. Thank you for watching this video, and do like and share this video. Thank you.